Fetal Alcohol Spectrum Disorders in Children webinar. During the presentation, all participants will be in a listen-only mode. Afterwards, we will conduct a question and answer session. At that time, if you have a question, please press the 1 followed by the 4 on your telephone. If you would like to ask a question during the presentation, please use the chat feature located in the lower left corner of your screen. If you need to reach an operator at any time, please press *0. As a reminder, this conference is being recorded Wednesday, July 13th, 2011. I would now like to turn the conference over to Amanda Hopping-Wynn. Please go ahead.
Thank you. Hello, welcome to our second teleconference in our 2011 series. I'm Amanda Hopping-Wynn, Project Analyst here at the National Abandoned Infants Assistance Resource Center, located at the University of California at Berkeley. Funded by Health and Human Services Children's Bureau, our mission here at AIA is to enhance the quality of social and health services delivered to children and families affected by substance abuse and/or HIV by providing quality training, information, and resources to the professionals who work directly with these families. On behalf of the Resource Center, I would like to welcome all of you to today's teleconference training on assessing for fetal alcohol spectrum disorders in children with Hargrove and Cecily Hardin. Ms. Hardin, LCSW, has been affiliated with the Child Guidance Center in Jacksonville, Florida since 1989. Former positions include Director of Intensive Crisis Counseling and Director of Family Casework Services. Cecily is now coordinator of the Fetal Alcohol Spectrum Disorders Project and recently completed training in child-parent psychotherapy through the National Child Traumatic Stress Network. Hargrove, who's also an MSW, has been a technical assistance liaison with the SAMHSA FASD Center for Excellence for 6 years, where her work focuses on the screening, diagnosis, and intervention services for children and families. She's responsible for the management of the FASD Diagnostic and Intervention subcontracts. Before we continue, I'd like to review a few important administrative details. To eliminate disruptive noise, only the presenter's line will be open throughout the entire call. If you need individual operator assistance, dial *0 at any time. Your discussion with the operator will not be audible to participants. If at any time you have questions for the speakers, please write your question in the chat box located on that bottom left-hand side of the screen and send to chairperson. For those of you who are participating by telephone only, there will be 4 times during this presentation when you may call in with your questions. Once prompted, press 1-4 on your phone to be placed in line. If at any time during the training you're disconnected, please just dial in again. You can be reconnected at any time without interrupting the proceedings. If you encounter any problems with the web portion of the call, please jot down your problem in the chat box located on that bottom left-hand side, and a ReadyTalk representative will assist you. We do value your feedback and would appreciate it if you could complete a brief online evaluation after the teleconference. It will automatically appear on your screen after the end of the webinar. At this point, I'll turn the call over to our first presenter, Hargrove.
Good afternoon, everyone, or morning, as the case may be. Thank you so much, Amanda, for inviting Cecily and myself to speak with you all about FASD. We're excited to be able to share the information and see ways that you can be able to use it in your work. And we particularly would like to thank all of the participants for their interest in what they can do with children who might have an FASD. At this time, we want to pause for a moment to get your input so that we can tailor our presentation to your needs. You will see a question, or you see a question on your screen about how much knowledge you may have of FASD. That is none, very little, moderate, or extensive. If you would click on the button that best indicates your response, then we will be able to make changes and adjustments to the presentation to work with you. So I'll give you a moment to answer the question.
Okay, Catherine, it looks like
go ahead.
Many of the people have answered.
Okay, and it looks like what we have is that the majority of people either have very little or moderate knowledge about FASD. So what we want to do, and we will tailor that to your needs. So one of the things we want to do, and I'm going to skip first to deal with the objectives because we know how much knowledge you have. We want to provide, one of the objectives is to provide a basic knowledge about FASD so that we can all have a common reference. And then once we have a common reference, then we will be able to give you information about screening, referral, and diagnosis, and a particular approach that relates to children ages 0 to 3. Now, what you see here is a case study, and as we begin to think throughout the process, we'll look at what kinds of cases that we see and you may potentially see. We have a child who is almost 4 who's been placed in foster care after the mother has given birth to a girl who had meth in her system. And in that particular site, the children who have born with drugs in their systems, there's a referral to Child Welfare Agency. As a result of an investigation, all the children are removed from the home. And in that site, we do a screening of all children in child welfare who come through the court, and that child screened positive for an FASD using the Northrop Grumman screening tool, which we will discuss with you later. In that instance, the mother admitted to use of alcohol, marijuana, and meth during her pregnancy. And we see more about the mother, that she has a diagnosis of bipolar disorder and completed the 10th grade. So you see the intersection of the drugs and the alcohol and a process of beginning to stabilize a child's life. So think about that kind of case or the cases that you have throughout your work. So what we would like to do now, as we've seen the objectives, to share information with you about FASD, the screening tool, which is referenced in the case study, and a model for working with children 0 to 3. And Cecily will share how they've integrated screening into their system at Child Guidance Center. So now we will look at what is FASD and why diagnose. Cecily will share with you an overview of FASD, beginning with the language, including with why a diagnosis is important. There are additional resources that can be provided to you, and you will be given a website for the center where you can get more resources. Cecily?
Okay. Thank you, Catherine. Actually, FASD is really an umbrella term that encompasses lots of different variations. So it's not a diagnosis in itself, but it is the umbrella that we use. Some of the diagnoses that we see that are, and these are all medical diagnoses, are partial fetal alcohol syndrome, static encephalopathy is one that we see a lot, where kids are sort of in the middle of the spectrum, and partial FAS and fetal alcohol effects. So it just gives us a little bit of knowledge, but it's not in itself a diagnosis that you can use in a mental health setting or even in a medical setting. And again, fetal alcohol spectrum disorders are caused by prenatal alcohol exposure. That's the only way that you can get a fetal alcohol spectrum disorder. And it results in birth defects and developmental disabilities. But there is a wide range from very severe to very mild, which makes it difficult to pick up. Again, and we don't know at this point how much alcohol will cause damage. There's still no definitive research on how much. So the American Academy of Pediatrics recommends no alcohol intake at all while a woman is pregnant. Okay. Again, FASDs are the leading known preventable causes of mental retardation, so it's totally preventable. And the prevalence of FAS in the U.S. roughly about 0.5 to 2 per 1,000 live births. The prevalence of others on the spectrum, FAS, ARND, and ARBD, which is alcohol-related birth defects, combined is at least 10 per 1,000, or 1% of all births. And thus, based on estimated rates of FASD for live birth, nearly 40,000 infants born each year have an FASD, and that's quite a significant number. And then why diagnose an FASD? There really is no cure for an FASD, but the diagnosis does confirm disability based on brain impairment, which sort of reframes some of the disabilities that we see in kids, and it helps us look at other interventions that might help them be successful. They can help to improve outcomes with a targeted treatment plan, and they may qualify a child for accommodations in educational settings, which is where we see a lot of the difficulties that these kids have. They may have normal IQs, and they may look like they're functioning normally, but they just don't have the capacity for understanding that kids without a disability would have. So they end up getting in a lot of trouble in school, and they have poor success rates without some intervention. And for those kids that end up in the mental health system, which is where I am, it reframes their behavioral problems and provides access to other services. Some of the indicators of need for assessment would be positive results of screening for an FASD, and I think we talk a little bit later about the screening tools that we use. If they have any physical deformities, a small head or facial or dental abnormalities, that might be something you'd want to think about. Joint, limb, and finger deformities, vision or hearing problems, heart or organ defects, which we don't always see, but the primary care physicians do. A lot of, especially the babies, may have sleeping, breathing, or feeding problems, and of course maternal alcohol use. We don't always have that information when the kids come in, but that's a question that we need to ask. And then the 4 key diagnostic features of FASD are prenatal alcohol exposure, the characteristic facial anomalies, which we use a facial photographic software to determine those, central nervous system abnormalities, and that can be anything from behavior problems to developmental delays, and growth deficiency, and that can be at any time. It could be premature birth, or if the child could be small, under 5% on the height and weight scale. Some of the common co-occurring disorders that we see are ADHD, the attention deficit disorders, bipolar, major depressive disorders, oppositional defiance, anxiety disorders, PTSD, and disruptive behavior disorders are the ones that we see the most in the mental health setting. I think now we have a little bit of time for some questions, if anybody has questions.
Operator, we'd like to open the line for questions.
Thank you. Ladies and gentlemen, if you would like to register for a question, please press the 1 followed by the 4 on your telephone. You will hear a 3-tone prompt to acknowledge your request. If your question has been answered and you'd like to withdraw your registration, please press the 1 followed by the 3. And if you'd like to ask a question, please use the chat feature located in the lower left corner of your screen. One moment, please, for our first question. Our first telephone question comes from the line of Deborah Barnes-Josiah with Nebraska Department of Health and Human Services. Please go ahead.
Thank you. Is this coming through?
Yes.
Yes.
Yes, I was just curious, in the slide that said some indicators of need for assessment, and you listed heart or organ defects, that's pretty broad
Yes.
characterization, and is there any way to narrow it down a little better?
I'm not sure. I know that I don't know that specifically. I know that could be mitral valve. Is mitral valve bowel problems are one of the things that they see commonly for the heart defects. And I'm not really sure about the others. I would want to ask a physician specifically about this.
Okay, thank you.
We can, this is Catherine Hargrove, we can get you some information on some other possible things, because the heart problems in and of themselves may not, are not necessarily indicative of an FASD, but in some other combinations, they may be. So I can get you some additional references as to what kinds of heart conditions may be more closely associated with FASD.
Mm-hmm.
Thank you. That'd be helpful.
And we'll have your name, so I'll get that back. We'll get that back to you.
Also, Amy Martin was wondering what type of dental abnormalities.
They tend to have small teeth, a lot of the kids, and some of the kids have teeth that are spaced far apart, and some of the kids have like poor enamel covering. So those kinds of things.
Are there any other questions, operator?
There are no further questions over the phone at this time. However, ladies and gentlemen, to register a question or comment, please press the 1 followed by the 4 on your telephone keypad. And we have no audio questions at this time.
Okay.
Okay. And I think.
Thank you very much for your questions. And one of the things is, again, we have a number of resources at the Samson FASD Center for Excellence that we can share with you, and we will get those out to you. The Samson Center for Excellence it has initiatives that we'd like to talk with you about. They are the ones that we will primarily deal with here, focus on children who are 0 to 3. The SAMHSA FASD initiative is devoted to preventing and treating FASD, and its purpose is to decrease the incidence of FASD and to improve the quality of life. There are 7 contracts that we have that focus on a priority population, and those populations are children in the child welfare and behavioral health systems. And many of you probably already could understand why we focus on children ages 0 to 7, is that fetal alcohol spectrum disorders are underdiagnosed. And we also know that early diagnosis of an FASD and intervention can help improve the lives of children and families. So what we want to do is to get in at the earliest possible moment, because there are things that we can do to work with children and their families so that there can be improvements in their lives. The other thing about it is that we can develop interventions that are based on the diagnosis and that are apt to be most effective in meeting the needs of the child. The interventions are based on what it is that is the diagnostic provider determines as important to focus on in terms of the FASD. In our program, we have 4 service components. That is, we screen for an FASD. We monitor children who are ages 0 to 3 who have a positive screening result for an FASD but are asymptomatic. And we refer children with positive FASD screening for a diagnostic evaluation. And we provide interventions based on the diagnosis. Now, what people want to know is, how do we do the screening? At the center, there was an FASD screening tool that was developed, and it was developed using an expert panel. The panel looked at the literature. We had input from them about what they knew about FASD, and we had the experience of prior subcontracts. One of the things about the development of the tool is that we wanted something that could be integrated screening criteria is, we'll discuss that now, is that the screening criteria that included for the 0 to 7 was anyone with a face rank of 3 or 4 as measured by the facial photographic screening tool for FAS. There is a tool that is also used as a diagnostic tool, but we used it as part of a screening tool, and it is a rank 3 or 4, and you can find that on the University of Washington website, and all workers were trained in the use of that tool. The other criteria was a sibling with a diagnosis of an FASD, a child with a previous diagnosis of an FASD, and confirmed prenatal alcohol exposure. While any one of those things could be basis for a referral, one of the things that we learned in working with the programs is that because an FASD requires confirmation of a prenatal alcohol exposure, most diagnostic centers would want to have that there's confirmation of prenatal alcohol exposure. Another criteria for referring for children 0 to 7 was a birth mother with a confirmed history of drug or alcohol use at some time other than pregnancy, and one of the following characteristics: that the child had a growth deficit, or there was a central nervous system or disorder, or a developmental abnormality, or there was a medical note of dysmorphia. So that is the screening criteria that we use. Again, we looked at all of those as being a basis of referral, but we do know that in most instances, all of the sites required confirmed prenatal alcohol exposure.
And Catherine, I'm just going to interrupt for one moment. I do believe that the participants received the facial photographic screening tool beforehand. It was one of the resources that we provided via email, but it will also be available on our website after this presentation. Okay.
Also, there is the, go ahead.
I can also advance your slides if you'd like. If you just want to say next slide,
I would prefer that, because I'm getting many of you confused, and even though I cannot hear you, I can just see it because it is distracting to me. So thank you very much.
No problem. Just say next slide when you're ready.
Okay. The other thing is that the University of Washington website will also, there is excellent training for the use of the photographic screen, but please note that we are using it for a screening purpose and not for a diagnostic purpose, and many of the diagnostic centers do another facial photographic analysis. Even if they do not use that tool, they may use their own hand analysis, and I'm sorry I stuck my hand on it again. So next slide.
Okay.
What you see here is a case study where we're going to talk about something I think has become important. Is here you have looking at a premature female child who tested positive for cocaine in their system. The child was born with an undeveloped lung and digestive tract, so they remained in ICU. The judge ordered that the child remain in the state's custody. One of the things, again, in that system, we do screening of all children who are in the dependency court, and that child received an FASD screening and received a face rank of 3. And you can see in that instance, you could make a referral just solely based on that. Based on that, the mother reported drinking gin daily for the first month prior to the knowledge of pregnancy. She also confirmed that she was drinking during pregnancy. The child was released from the hospital after 4 months, and the child was placed in positive monitor status. And later I'm going to talk about positive monitor status and why it can and could not be used in this instance. In this case, the mother's parental rights were terminated, and the child was adopted in the fall of 2010. What's important here is that the knowledge of the FASD and the interventions, one, did not prevent the child from being adopted, but did provide the parent with some knowledge of what kinds of things would be needed to assist the child in their development. In this instance, the child is confirmed with an FASD diagnosis. Next slide. The criteria for positive monitor, and let me say a bit about how it came about, is that we were in one of our contracts, we were learning that there were some children where you could confirm that there was prenatal alcohol exposure to alcohol or drugs, but there were no current growth deficits or central nervous system abnormalities or developmental delays, and there was no medical note of dysmorphia. But we also knew that it was necessary to monitor the child because of the awareness that the child had been exposed to alcohol and the potential for an FASD. So you see the labeling of positive, that is positive for alcohol use, and monitor to indicate what we do. So we can move to the next slide. The monitor is that, okay, the monitor, again, I told you about why we did it and how we did it, is that an early diagnosis can lead to early intervention. So we didn't want to leave out children who were 0 to 3, but we knew that people could possibly, other agencies were in there working with them, and as is the case with our subcontracts now, is that they continue to monitor. One of the things about our current subcontracts is that we've developed a database, and so we, as part of their services, is if a child falls in positive monitor, they are monitored them every 3 months to determine whether they have in fact become symptomatic. And we can monitor at any other time when the worker or family finds appropriate. So you don't have to wait till that 3 months, and you can see if you're going into a home, a child, you can learn information about the child so that you can in fact monitor them. Next slide. What we think is important in this process of screening and referral is that the programs are integrated into existing agencies and that they are coordinated among multiple service providers. Is that I'm not telling you anything new, but care for children does not belong with a single agency. So therefore, we have to really coordinate and collaborate with a number of agencies. We think it's important when the FASD screening is integrated into the existing agencies, because one is that when we go away as subcontract funders, the agency needs to be left with a program that can be sustained. It's a part of the work that is done. So we see with our current subcontractors, and Cecily will be a great example of that, is that it is integrated into the existing agency. It's a part of the way that they do business. And shared case management is that while we in our systems focus on the FASD component, but the children are parts of other systems such as child welfare, so we share the case management and come up with the best plan for the child. What you will have as a handout is a handout that shows our 8 subcontracts where FASD services have been integrated into the existing systems. 4 of those are in court systems, and we have 2 projects that deal with delinquency, and we have 3 that focus solely on children 0 to 7 who are in dependency courts. We have 1 project where the integrated in a state mental health system. And we have 3 subcontractors where the FASD services are integrated into behavioral health systems and into a community agency. So again, I think the funding helps to get the program integrated into the agency, but the collaboration and the coordination ensures that the program continues and works for children. Next slide. The outcome objectives of our initiative, which are much similar to what many of you have, is that we wanted placement stability in the home setting. And the other thing is improved school performance, and that is, again, for school-aged children. One of the things we wanted to do is, with regard to outcome objectives, again, we looked at some of the current outcome objectives for child welfare initiatives, because we thought that it is best to have programs that are part of existing programs, so we were not trying to measure something that other people, were not already measuring. Some of the other outcome objectives that subcontractors had was reduction of stress on caregivers. While we say we focus on children, it is correct to say we focus on children and families, because the child does not exist independent of the family. So one of the subcontractors looks at how the interventions and support the reduction of the stress. And again, because we are looking at younger children, is that some are not in school, so we wanted to look at the placement stability in daycare or preschool settings. And we actually have one site that looks at a daycare setting for children who have an FASD. Next slide. One of the things that has been important, and I think as I began to look at recent legislations and all that we do, is that yes, we do talk about screening, which is critical, but the other piece we know that is important is having some diagnostic capacity. You really look at those in hand, because one, you don't really want to. We didn't want to screen our ability to diagnose. We wanted to make sure there is capacity to diagnose. And we also looked at the ability of centers to work with children 0 to 3. Different diagnostic centers may use different criteria. They require different materials from the people who are making referrals. So the diagnostic center or the team, that's a critical player in the process. Yes, we can begin to screen, but if we want to say we have a diagnosis under the FASD spectrum, we need to have diagnostic capacity. Also, I think it is important that as you begin to look at screening, you know that particular criteria that your site is using, because it helps you to understand how you use the screening criteria. For instance, earlier this morning I was talking with a site, and they said that even though our screening criteria says the referral criteria is the use of a 3 or 4 on the facial photographic screen, they said to me, our diagnostic center says what they think is adequate is the use of a hand measuring. So even if we give them the rank of a face rank of a 3 or 4, they're going to do hand measurements themselves. What we know is that there is a measurement, but we, on the other hand, know that that is not the meaningful criteria for that. So again, we have gone from looking at what is the screening criteria that we use, how it is used, and the importance of the diagnostic services. I'm going to stop here for questions and answers, and I know I talk fast, and I get enthusiastic about it, so I could talk on. So now is your time to ask questions.
Operator, we're going to open the line for questions.
Great. Once again, ladies and gentlemen, to register a question over the telephone, please press the 1 followed by the 4 on your telephone keypad. To register a question Via the chat, please use the chat feature located in the lower left corner of your screen. One moment, please.
And it looks like Deborah Barnes-Josiah has asked if you could expand on the bullet point that speaks of genetic testing confirming FAS diagnosis.
Genetic testing confirming FASD, some of the diagnoses under the spectrum may look like some other diagnoses. So in some sites, what they do is that if there is not clarity regarding what the diagnosis is, then they refer to a geneticist who does some more extensive testing to determine whether it is an FASD or whether it may be some other diagnosis. And some sites also may have a geneticist as part of their FASD team. But I'm most familiar with one site who, when they are not certain whether it is an FASD, they refer out to a geneticist. Cecily, did you want to add anything?
I just wanted to say that we use the geneticist is the one that makes the diagnosis. We do not do that. We will refer to them and give them all the background information, including the facial photographic analysis and other evaluations that we've had done by other providers. And then the geneticist may want to do some blood testing and some chromosome studies sometimes to eliminate things like Fragile X syndrome or some of the other syndromes that might look like FAS-Williams syndrome, I think is one that comes to mind. But there's really no blood test or no chromosome study that will determine fetal alcohol. It's mainly a rule out. And then with the compilation of all the other information is how he makes his diagnosis.
And that's one example, again, when you use how you work with your diagnostic center. Cecily explains hers. Others do use a diagnostician when they're going to rule out.
Mm-hmm.
Also, Toilet Green Harris has asked if you could expand on FASD screening exceeding diagnostic capacity.
Yes. What we did is to try to look at whether if you screen so many children and can't diagnose them, they come up positive, what are the ethical considerations? Now, here's what we have done in some sites is, say, for instance, the age range is 0 to 7. What we did in some sites is that because they did not have the capacity to diagnose all of the children who may screen positive 0 to 7, they made a decision in one instance to screen children 2 to 5 and would screen children 0 to 3 if they were a sibling of a child 0 to 5 who was 2 to 5 who had screened positive. So that way they knew how much diagnostic capacity they had, a sense of children who were screening positive. So if you will have to look at what your diagnostic capacity is. Now there's another perspective, but just falls outside of the subcontract is, and we've discussed that, is that when you are screening children who are in systems that are receiving services and they get a positive diagnosis, how long can you wait for a diagnostic evaluation because they're receiving existing services? Now that is a question, but it does not necessarily allow you to tailor the interventions if the child were diagnosed with an FASD. So we try to, and again, we have subcontracts. We're trying to make certain that all of the children who are screening positive can get a diagnostic evaluation within a reasonable time. Did I answer the question?
There hasn't been a follow-up. I'll let you know if there is.
Okay.
Kelly Roth Rosenbrook has said, hello, I'm a parent educator doing intensive home visitation through a school district with children prenatal to 5. Did I understand that on the University of Washington website, I could find information about a screening tool that I can be trained to use in my home visits with families?
Okay. I think on the University of Washington, you can find the FAS photographic screening tool, and that's for the facial features. One of our sites does screening in the home setting, and what the screening is about is a number of things about, finding about the prenatal alcohol exposure, the face, whether they're siblings. So some of these things you can find out in records review. The other thing I think is interesting in terms of the facial piece, which is covered on the screening through the University of Washington, is taking a photograph of a young child and the type of photograph that is required, because children are active and there are certain features that you're looking for, so you learn how to take that photograph. Let me take this minute to also say that in some instances the photograph has been easier to integrate into systems because the agencies are already required to take a photograph. But also let me turn it over to Cecily because they do photographs in their setting.
Okay, the photographic facial analysis, you can buy the software, I believe, still from the University of Washington, and there's an online training to do it. It's not a really simple thing to do. You have to put a sticker right on the child's head in the middle of their forehead as a baseline measure, and then you take the photograph. You have to have 3 views. You have to have a full face with their eyes wide open and their mouth relaxed. So I'm sure you understand what a challenge that is with very young children and babies. Some are really good and some you have to chase around. And then you do a lateral view, and then you do what's called a 3/4 view, where you get a really good picture of the philtrum and the upper lip. Those are the measurements that they're looking at. They're looking at the eye slits, the distance between the eye slits, the philtrum size and definition, and the upper lip. So I worked on an earlier grant where we used that, but it's just a piece of the diagnostic tool, so it's not always.
It was mentioned that a screening tool was developed for SAMHSA's FASD Center for Excellence. Is that available to the public?
Yes, I can publish it in just the criteria. It's just the screening tool that we developed. I'll put it on a one-pager. So I will do that as a one-pager. One of the things about the facial features is that a large number of the children under the FASD spectrum do not have the facial features.
Right.
The facial features are as part of the literature, are predictive, but again, they don't have the large number of children don't have it. But I will put the screening criteria on a one-pager and make it available to you,
After the
Amanda.
presentation, that would be great, and we can send it out to participants and post on our website. In the interest of time, I would like to take just a question from the phones, if there are any, and then move on.
Okay.
There are currently no audio questions at this time. However, ladies and gentlemen, to register a question over the phone, please press the 1 followed by the 4 on your telephone keypad.
Okay. Cecily, I'd like to turn it over to you now.
Okay.
Let me say a little something before Cecily begins.
Okay.
We think that this is, as part of our project, we think that Cecily's project is a good model of how you can integrate FASD screening into an agency and to sustain the work. So I interrupted to give her the accolade.
Well, thank you. I appreciate that.
Cecily, would you like me to advance your slides, or would you like to do it?
If you could do that would be helpful. I think the next slide actually was, I just wanted to get an idea of who maybe was incorporating FASD screening at their agencies now.
you'd like to go ahead and just click yes or no, we'll get this poll going.
Okay, looks like not too many. Maybe some, okay.
Looks like the majority are not.
Okay. All right. Okay, then the next slide, I guess, is I just wanted to do a brief case study. This is a child who, a 7-year-old Caucasian male who lives with biological mother, her paramour, and 3 siblings. She reports drinking before she knew she was pregnant. He was referred for in-home counseling because of a child welfare report due to hazardous conditions, inadequate supervision. He also had an extensive history of exposure to domestic violence and other trauma. But because he was a client of our agency, we were able to enroll him and screen him and found out that he did in fact have some difficulties related to prenatal alcohol use. So he went through the diagnostic process, and he was about in the middle of the spectrum, which is where we find most of the kids. So they don't have severe facial features or physical features, but they have a number of behavior problems and learning disabilities and some sensory integration problems related to prenatal alcohol exposure. So we were able to develop a little bit more comprehensive of a treatment plan than if we had just looked at him as being a behavior problem and exposure to domestic violence. And then next slide, Child Guidance Center is just we're a private not-for-profit organization in Jacksonville, Florida. We accept Medicaid as well as other insurances. We have about close to 6,000 children per year that we see in different programs. And our mission is to provide quality mental health and social services to children and their families, and we're supported, at least a part of us are supported by the FASD Center project. Okay, next slide. The services we offer are outpatient counseling, in-home, and school-based counseling. We have a contract with our county school system to serve kids that are in severely emotionally disturbed classes. We have case management, psychiatric services. We have 2 full-time psychiatrists on staff. We do daycare consultation. We have some child abuse prevention contracts, and we also do supervised visitation for the dependency system. And for the integration for the FASD project, we have a parent orientation packet that each parent has to come in before their child receives services, and they fill out, hundreds of forms, but consent to treat and things like that. So we integrated the consent for screening into that form. So it's on, I think there are 4 different lines that they sign, which seemed a little bit less threatening to parents than having a whole separate permission for screening. And so our policies and procedures were revised to include the FASD services at all levels. And children ages 0 to 7 years receiving behavioral health services or case management are referred for screening for an FASD with the consent of the caregiver. We still have a number of caregivers who do not want to give consent. Okay, next slide. We use the screening process is to use the software, the facial software, and a file review. And we consider a positive screening result a score of 3 or 4 on the facial analysis, or a score of 2 plus confirmed prenatal alcohol exposure. And then we do the referral for the diagnostic evaluation. You can go to the next. Okay. And we have a networking diagnostic model. We're not an all-inclusive center. We just do pretty much behavioral health services. But our diagnostic team includes other providers that we've made connections with in the community. So there's a licensed clinical social worker, there's a psychologist that we contract with, there's a speech and language therapist that we contract with, an occupational therapist, and a geneticist. So, and we are in a large geographical area, so a lot of the time have to drive really literally from one place to another in order to get the complete diagnostic evaluation, and we do assist families with transportation. There's 22 different clinical diagnostic categories that are, there's a 4-digit code with just, hundreds of possibilities. And then once you get each 4-digit code is assigned in one of these categories, which I talked about a little bit before. Okay, so you can go to the next slide unless anybody has specific questions about that. And the availability of diagnostic services in Jacksonville, Florida is not all that child-friendly, and sometimes it's really difficult to find the resources. About 35% of our population is served by Medicaid, and Medicaid is used, or other insurance, to fund most aspects of the evaluation with a referral from the primary care provider. So usually we don't have any trouble getting a child an occupational therapy evaluation or a speech-language evaluation or the genetics evaluation. However, we don't have very many providers that will take the Medicaid reimbursement for a psychological evaluation. So in those cases, we try to use the Part D and C providers for the Individuals with Disabilities Education Act to help with those services. And that would be, we call it Child Find Here, that assesses children 3 and up, and then our Early Steps program is children 0 to 3. So we try to get those kind of evaluations done there so there's not a cost to the families. Okay, next slide. And then designing the interventions once a child is diagnosed. So the children with FAS or an FASD have a degree of differences in their brains. So it logically follows that they could benefit from what others with more obvious handicapping conditions have provided, which are the environmental adaptations. And I have a quote from Diane Malvin that part of our job is to remove the cognitive barriers, prevent those in cognitive wheelchairs from being asked to perform cognitive high jumps. So a lot of what we do is advocacy with the school systems and with some of the other providers and getting them to look at these children differently and recognize that they do have a disability even though it's not visible. Okay. And I'm working with the therapists here. We do a lot of training so that they can reframe maybe what they're doing, because some of the typical therapies don't work with kids, and when I hear from therapists, I've done this, this, and this, and it's not working, but adding some different dimensions sometimes is really helpful. So it's important to keep information really concrete when dealing with these kids, and look at, again, whether their poor behavior is physically based unmet need or intentional misbehavior. Reframing makes a huge difference in approaches from parents, therapists, and school personnel. It's important to be consistent, to use repetition, to establish stable and consistent routines, keeping it short and sweet, which is probably a good rule for all young children. Being specific, saying exactly what you mean, creating structure, providing supervision, and that treatment planning should develop a comprehensive report and recommendations, sharing the report and recommendations with everybody that's working with the child, and that can be a therapist, a mental health therapist, an occupational therapist, school personnel, and a parent, and to try and adjust the approaches and add services as are necessary. Okay. And one of the things that I've learned a lot about and dealing with the FASD, kids affected with FASD, is that a lot of them have sensory integration difficulties. Sensory integration impacts their ability to concentrate and organize, academic learning, their capacity for abstract reasoning, their specialization of each side of the body and brain, their self-esteem and self-control. You can go, the next slide is a good illustration of normal versus we take it for granted that we're in a workshop or on a webinar, and we know we're supposed to be paying attention. We're supposed to be looking at, my screen is blank. What we're supposed to be looking at, and we're pretty good at filtering out the things that we know we're not supposed to attend to. But kids with sensory integration disorders, which is the bottom part of the slide, just cannot make sense of that. And that's one of the areas where occupational therapy has been really, really helpful in designing interventions that I, as a mental health provider, would never have thought of, things having to do with touch and sound and teaching kids how to manage those sensory inputs. Okay, go to the next one. Again, what works? Traditional talk therapy is not helpful due to the language, memory, and attention problems typical of individuals with an FASD, and of course that's what many of us mental health people are trained to do. But psychotherapy with adaptations can be beneficial. Being creative, allowing kids to use manipulatives and different kinds of materials, drawing materials, clay, Play-Doh, sand, any kind of thing they can touch. Persistence and clinical intuition are essential. Client-centered care is important, so focus on the concrete issues, dealing with the disability, supporting the child and the parent. Parent support is a big component. And again, taking a multidisciplinary approach, bringing in an occupational therapist, or bringing in a speech and language person, and bringing in the educational community, and trying different approaches to help children learn. Using family therapy, using role playing with kids to practice things. A lot of these kids have very poor social skills too. That's a big problem. And again, presenting information in multiple modes. Simple step-by-step instructions. Pictures are helpful, even in kids that are a little bit older, that you think they should know that, they need to brush their teeth, and they need to make their bed, and they need to wash their face, and they do that every day, but they need to be reminded every day. Okay, go to the next slide. And the project data so far, from November 1st through May 31st of this year, November 1st of 2008 through now, we've done 540 screenings. We've had 59 positive screenings, 35 completed diagnostic evaluations as of that date, and 31 children with a diagnosis of an FASD. We do have some families that drop out. Some families, we do have somewhat transient population, and they may move before they complete the diagnostic evaluation, or they may, sometimes the families become anxious about getting that diagnosis and just don't want to follow through. So I think the next slide then is for questions and answers. I know I went through those pretty quickly. So.
Operator, we're going to open up the line for questions again.
Thank you. Once again, ladies and gentlemen, to register a question or comment over the telephone, please press the 1 followed by the 4 on your telephone keypad. To register a question via the chat, please utilize the chat function at the lower left corner of your screen. One moment, please.
So, Deborah Barnes-Josiah has said much of this seems to depend on getting birthing hospitals to do a better job of screening for maternal alcohol use and/or referring suspected infants. Any thoughts on how to encourage hospitals to follow these practices?
Well, I've done in other areas with other grants, but just a lot of education with primary care providers and in-home visitation programs with babies. Like, we have Healthy Start, which actually is a prenatal visitation program as well. But just getting the information out there, I think it's a question that we don't ask. Hospitals look at other drug exposure sometimes, but they don't always look at asking about alcohol, and a lot of physicians are reluctant to do that. So I think a lot of it is education. and encourage them. I don't think people realize the impact that alcohol has on the developing child. Catherine, I don't know if you want to add any more to that.
I think Cecily is correct, and what some of the sites have have hospitals as part of their task force. But again, as Cecily is emphasizing, it's a matter of beginning to make people aware of that, and you do screen for the drugs, and one possibility as people become more aware is that to do the screening in conjunction with the awareness that there are in fact there has been drug exposure. But again, it's a lot of education and awareness and seeing how it fits in the bigger picture and the significance to the child.
Thank you. Miriam Menzel asked, have you been successful in getting public school districts to fund occupational therapy for sensory integration processing issues?
No, not really, because unfortunately the school system has a different criteria for what they consider an occupational therapy need. So we've had some struggles with that. It has to directly interfere with their academic success, and they have a very narrow definition here. But what we've been more successful with is having Medicaid or insurance pay for additional occupational therapy with the recommendation from a primary care physician. So once we give the primary care that information and that they're not eligible through the school system, we've had more success with getting it from another provider.
So there does seem to be a workaround there.
Yes.
And another workaround is, not necessarily workaround, is that all of the sites have some involvement with trying to get schools, to work with the child on their specific diagnostic recommendations. And that, they've provided various approaches from making people more aware, working with them individually, advocates. But the school piece is such an important piece for all of the children.
Lisa Westphal has asked, does a diagnosis of FASD change as an individual ages, or is it a lifelong diagnosis?
It's a lifelong diagnosis, pretty much. Some of the manifestations may change as they learn to, accommodate for things, but the FASD diagnosis does stay.
And since it is a lifelong diagnosis, beginning at, you looking at where the child is at each stage and planning for that becomes very significant, and being able to have a plan that continues with the child. An important piece of that is working with the family on understanding what it will mean throughout the child's life for the child and for them.
Mm-hmm. I'm going to take two more questions here, and then we'll move to the phones. Andrea Danielson asked, can you elaborate on focusing on concrete issues?
I would just like specific behaviors would be the concrete issues, and those can be things like parents say one behavior might be that they don't listen, and then putting specific steps into place to help the parent use shorter directives and use one thing at a time, and then working with the child on making face-to-face contact. So things like that, just picking out specific things, because parents often make general statements that are hard to pin down. So getting down to the details, or they're defiant, or they won't go to bed, but getting down to more specifics and just working down to that level so that you can have specific interventions for each type of behavior.
And then last question, Toyley Green Harris asks, with collaborating with community partners, do you use individual linkage agreements or a universal collaborative agreement to determine how each partner's role is clarified and to avoid duplication of services?
We use,
go ahead.
well, we use individual agreements, and there's really very little chance of duplication of services. So, but for our model, we use individual agreements with each provider.
Do we have any phone questions, operator?
We do have a question from our telephone participants, and it comes from the line of Sasha Bayer with Eastern Shore CSB. Please proceed with your question.
Hi, yes, am I on the line?
Yes.
Calling to find out, I'm interested in understanding, I have a background more in developmental disabilities and understanding the differentiation between funding and also for types of programs that are implemented for people with or children with FAS versus a developmental delay.
So you're wondering if there's specific funding available to children with FASD as opposed to other developmental delays, is that correct?
Correct.
No, not here. And I think maybe each state is different, but there's not specific funding for children just with FASD. And
But
sometimes
services seem to be covered by insurance?
they are covered by insurance, but not for specifically an FASD diagnosis. They have to have something else. So if they, for instance, if the geneticist says they have an FASD, he would have to put it coded as static encephalopathy or one of those other areas, which would be eligible for an occupational therapy evaluation to be covered. In addition to FASD, they would have to say that they have a sensory integration disorder or some
Something like diagnostic criteria that...
Yeah.
In the interest of time, I'd like to continue with the presentation.
Okay, we're coming to the end, and I think what we've seen is that learn more about FASD, the screening process, and you've seen how it has worked in child guidance centers. So what we want to, and Cecily and I will go back and forth and I'll talk about some keys to developing processes and procedures for assessing for an FASD that you can consider for your system. So some of the keys, and we'll go through this, is incorporating FASD screening into existing service delivery systems, making sure you have diagnostic capacity, building on the collaborative relationships that you have, and increasing the knowledge about FASD and screening skills. Integrating FASD screening into existing systems has been critical to our process, because it means, as you saw with Cecily, it's a part of what people do. While it may require that you continue to do training, but it's not a standalone program. Standalone programs are difficult to maintain, particularly because oftentimes when the funding goes away, the program goes away. And while there is a benefit to a program, if you work at sustainability in the beginning, you can find ways to sustain the program, not necessarily in the particular way that it was funded, but you can have FASD screening into the system. And we're pleased to see that many of our programs are being able to sustain because people are in fact looking at the value of them. Just before I got on this call, someone called me and said, I got good news for you. Someone has told me something about, they call me because they want to know how to deal with the captive provisions in our state. And they knew that this FASD project was a part of their system and would be sustained. One of the things that's also been important is building on existing collaborations and systems of care, as well as developing new relationships. No one agency can handle all of the things that go on for a child with an FASD. So it is collaborate and work with each other. And as someone asked in an earlier question, figure out who does what so that there will not be duplication, but there will be careful coordination. One of the things that we thought was important is performing screening for children in the population with a high risk of alcohol exposure. It's not universal screening. So one of the places you saw that we screened were in child welfare systems, children who were involved in the dependency court. So you can look at what kinds of populations are there where you are, where there are children at a higher risk. Then the other part we think, again, is building on relationships with the existing service systems. When we have children in positive monitor, oftentimes what is happening is the person who is the FASD case manager is calling someone else who is in another system, whether it's Part C or the child is with the child welfare worker, looking at what has happened during that period to see whether there needs to be a referral for an FASD. We think it is important that you engage caregivers in the monitoring process because they see things that are happening. The other thing in terms of working with the service delivery systems is it's important. While we think FASD screening is important, it is also critical to see how doing this screening benefits that agency as well and the staff. So if we're doing screening for FASD, what difference is it going to make to the staff? Will it mean, and the agency, will it mean that they're better able to serve children and to have better results? But the agency cannot just do it because we think it is a good idea, but what is beneficial to both parties? And again, we've already talked about building on the FASD diagnostic capacity. And we found that involving the diagnostic clinic in the task force, the meetings, have been very critical because they may see the child at the stage of diagnosis, but it's important for them to understand the process from beginning to end. I was recently at a site visit where the diagnostician said, okay, I think we can add in a new day to do diagnosis, because they began to be more aware of the fact that there were children who were being screened and needed to have a diagnosis, and they were able to work out more capacity. And Cecily will talk to you more about increasing FASD awareness and training.
Okay. As I said before, I think, I do trainings for my agency all the time, and it's one of the things that as a mental health therapist, I was not completely aware of. I think it's a question that we sort of skip over when we're doing the initial evaluation, but to try to hone in and be a little bit more aware of alcohol use by mom and the impact that would have. And that, I think, as we go along, the therapists are seeing the value to adding that other dimension and maybe looking at some other things that might impact the kids' behavior problems. I think it's really important to train intake workers, frontline workers especially, foster care workers, child welfare workers, people that do in-home visiting with moms and young children. And there's a lot of, there's training available, I'm pretty sure, through SAMHSA, through the FASD Center for Excellence, but just getting as much information as you can out there. And again, primary care providers, I think that's something that, physicians tend to skip over too. They don't always ask the questions about alcohol because alcohol is legal. So unless a mom comes in intoxicated, obviously they don't always think about that. So including specific questions about alcohol use, prenatal alcohol use, in any kind of agency forms. Okay. So, and also for our therapists here that are dealing with these kids now that it's in the forefront. We incorporate other trainings into our mental health trainings. So we bring in occupational therapists. We bring in people that talk about specific social skills training, and we do some parent support and education. That's really a key component.
The training.
Go ahead.
Go ahead.
Just learning how to design interventions around the child's strengths and abilities, because a lot of these kids are very creative and they have different ways of expressing themselves. So trying to use those to help the child be more successful, and introducing different components into the treatment modalities. Yeah.
Catherine, did you want to mention the SAMHSA trainings?
Yes, and forgive me if I interrupt. One of the things that did occur for me is that my network died. So
okay.
I'm looking at slides. Is that there's training through the FASD Center for Excellence, and I think the website is at the end. But as you begin to look at who needs to be trained, think about your system. I was recently in a conversation with two of our projects, the court projects, and one of the things that was significant for them was that the two judges had received FASD training at some point and became champions of the development of systems in their sites, such that the projects are implemented in their court system. So in one, all of the children are screened who come through that system. So as you begin to look at who needs to be aware, there are different kinds of information that people need and different points. But again, the website, there is a website will take you to where you can get more information about training.
And just in case that isn't provided here in the slides, we will send that out after the presentation.
And following up is, I think the next slide is what we hope to learn. Am I correct? One of the things that we want to improve the outcomes for children and their families, but what we hope to learn is how to design interventions around the child's strengths and abilities. Is that we want children to be successful. We want to introduce the different components into the treatment modalities. Is that children are receiving services, but we want them to receive the right kind of services. And that's why we go back to the beginning where we talk about screening children, and those children who screen positive, to get an appropriate referral for a diagnostic center. If they're diagnosed with an FASD, is to have them receive the services that are based on those interventions. Again, we've had some very successful projects, but we want to see FASD screening as a part of the services of more children, and your participation in the webinar has just been exciting for Cecily and myself and all of our agency. I think we have questions.
Did you want to touch on the opportunities for integration of FASD services?
Opportunities for integration. Here's some places I think that you can really integrate services in court and child welfare systems. Children who enter the foster care and adoption system are often at higher risk for an FASD because of the substance abuse problems. And Cecily spoke to how we actually sometimes maybe focus on the substance abuse and not necessarily focus on the alcohol. But now that you and all of us know more, we can put more emphasis on the alcohol. One of the things that someone raised with me about the adoption services is that their unit was particularly interested because if the screening were done, it would help parents to know if their child had an FASD, and it didn't prevent the adoption, but it in fact, as you saw in one of the case studies, allowed them to be more prepared for the kinds of things that they would be able to do. The second thing that was helpful in terms of the adoption unit was that it helped to prevent disruptive adoptions, is that when children were screened and if they were diagnosed, then in fact the appropriate services could be provided. So we see opportunities there in terms of the integration into both the court and the child welfare system. We have projects that are, although they are labeled as court projects, some are based out of the court while others are based in the child welfare system, which has been good because the worker in the child welfare system can quickly coordinate with the child welfare worker. Also,
I'm going to interrupt you just for a moment. We have about 5 minutes left, and I would like to open up the phone for questions one last time, if that's okay with you both.
Oh, that's fine. I could talk forever.
So, operator, if we could open the line one last time for questions.
Certainly. Ladies and gentlemen, to register a question over the phone, please press the 1 followed by the 4 on your telephone keypad.
And Kelly Rosenbrook had said, maybe you stated this and I just didn't understand, but is there a screening tool that does not involve the photographic software use that a home visitor could implement in the home to catch red flags of FASD? Is that the screening tool that you will be sending out after this presentation?
Yes, we for our project, we use the facial photographic screen. As you begin to look at what you would do in your system, you would have to make a determination is whether you wanted to use that as a part of your screening tool.
Okay. Are there any questions on the phone, operator?
We have no telephone questions at this time.
Toily Green Harris said, we just held a symposium on FASD here in Chicago, and some of our local WIC staff attended. Following our presentation, one of the nurses stated she would talk about FASD during her home visits. I'm glad it's on your list for integration.
Yeah, I think that's good. The frontline providers are essential. I also think I was going to mention substance abuse treatment centers that are treating women are a perfect place to try to integrate that. And some of those facilities have the capacity to have women with their babies. So we work with a center here as well.
And some of our other projects, some of the prevention projects also do work with WIC, and some of the other projects also have referral sources from women in substance abuse treatment programs. Mm-hmm. That's great that occurred in Chicago.
Cecily and Catherine, do you have any final comments before we close?
No, I don't think so.
I just want to thank everybody. We really appreciate AIA for inviting us to share the information. Any way that we can be helpful to you at the center, we would be pleased to, and we just appreciate your participation.
And that website is now up on the slide, at the bottom of the slide. And we just want to thank you both, Catherine and Cecily, for sharing your time, and also thank all the participants on today's call. If any of you have any colleagues that might be interested in listening, an audio recording and these slides will be on our website within the next 2 weeks. Again, we do greatly value and seriously consider the feedback of everyone participating in these teleconferences. A brief online evaluation form will appear shortly. If you can take a few moments now to complete the form, it will automatically be sent back to us. Since we would like to receive feedback from every participant, if you are participating in this call as part of a group, please be sure that each member of your party does receive the link and is able to submit their form. With that, thanks again so much to our presenters and to the rest of you for your participation. We hope that you found this to be a valuable experience, and we look forward to receiving your feedback. As a reminder, our next webinar training, The Effects of Stress on Parenting and Related Child Outcomes in Families Living with HIV, is scheduled for August 18th at 10 o'clock a.m. In addition, if you'd like the chance for some hands-on clinical learning on domestic violence, we're holding an exciting skills-building training entitled Hope for the Future, Ending Domestic Violence in Families here in Berkeley on September 21st and 22nd with Alice LaViolette, who's a wonderful presenter in the field. And you can check out our website, www.aia.berkeley.edu for more details on that. Thanks again, and I hope you all have a wonderful day.